Chris Brown and Joe Walsh here for another video on Murmur for Perc Axillary support. We're joined by the Director of Valvular Heart Disease and the Co-Director of the Complex PCI program at St. Cloud in Minnesota, Dr. Thom Dahle. Thom, thanks for joining us.
Thanks, Chris and Joe, for having me. Happy to be here. Looking forward to
really excited about this. Yeah, we're really excited.
Let's do it.
Well, I get asked a lot about why do Perc Ax for mechanical support, and I think it's a good thing to talk about. One of the reasons is really this. We all have patients that are coming in sick, in shock, or need PCI or some way to do mechanical support, and we all know that there's patients out there with this anatomy. I think in patients who don't have femoral access for mechanical circulatory support, most of the people I talk to are often like, well, there is no way to support these patients. What am I going to do? And I always argue the difference. I think that in someone who you're doing any kind of PCI on who doesn't have good femoral access, I always turn that around and say from the start, why are you not supporting this patient? What is your plan if something goes wrong? If you're planning on a regular PCI and someone who has no femoral access for any kind of mechanical support, and you're doing a radial PCI, what is your plan if something goes wrong? What is your skill level? What is your team's level of ability to do something emergently? Is emergency alternative access bailout even an option? Did you even look at it? Do you have the right equipment at your hospital? What do you have for that ability? And then the question is, why am I not supporting the patient up front? And I think that's a decent question to ask in these vasculopaths, especially when you look at it from the standpoint, at our center, we've done hundreds of Perc Ax for TAVR, for mechanical circulatory support, anything. And even at our center, if I decide someone needs Perc Ax support emergently, the fastest I can physically do it with our team, prep, drape, pump, access, everything in, is approximately 9 to 10 minutes. And that's someone who has lots and lots of experience. Now, if you're doing CPR on the patient, that's even harder. Or if you're a center who's never done that, forget it. Trying to learn this up front is not a great option. And it's one of the things when you're trying to look at, Bill Lombardi's podcast was talking about this as well. Learning new techniques in medicine. In order to learn new techniques, you have to practice them, and you have to practice them on patients who are better patients to start with, to learn from. You don't want to be practicing these new techniques for the first time on someone who's crashing or the worst of the worst patient. You really want to gain your experience up front. And I think complex high-risk PCI is a good place for that, to start kind of learning this technique, teaching yourself axillary access, because it's a controlled setting. You can learn it up front. And once you learn it on that aspect, you're going to be able to do it in an emergency setting. That's most important. But number two, then you can start thinking about it for whether or not you want to apply this as one of your alternative access sites for TAVR if you do structural heart disease as well. So it's a good place to start and kind of hone your skills on that. And hopefully today we'll talk about some of the basics, tips, and tricks that will help get everyone started.
Hey, Thom, I don't know if you're going to talk about this. I think a question that comes up is for an elective PCI, not like an emergent ACS type PCI, how do you determine that the femorals are not suitable for Impella? Are you getting an ultrasound up front? Are you getting CTs on your complex PCI patients that are going to need support? Like, what is your imaging test of choice? And then what do you feel like you can push when it comes to transfemoral versus this is definitely an axillary case, and just anatomically speaking?
Good question. So anyone that's referred, when we're thinking about complex PCI or surgical turndowns, we automatically, and our coordinator does this, automatically it looks to see if they've had any kind of CAT scan in the past, looking at their abdomen and pelvis. If they haven't, we always just get a non-contrast chest, abdomen, pelvis to really assess what our access is. I mean, usually from a non-con, you can assess, does the patient have severe calcified vasculopathy of their, distal anatomy? And that lets us know, even if you're planning a radial case, it lets you know what your bailout options, and it's important to know that up front. Because if they don't have a good bailout option, that's when you really need to start thinking about, maybe we want to do support up front from axillary. And I think in choosing the patients or what's borderline, we'll kind of talk about that in the patient selection of that as well. So here's an example of, getting a non-con CT. You can see you'll have very severely calcified femoral. So if you see this in this patient, they have no femoral access. You see their common iliacs are terribly calcified. Even the right brachiocephalic is calcified. And so these are some of these patients that you can identify on that. Here's an example of a patient who a partner came in with an MI. This was their femoral access that they got, and we reviewed that, can see that terrible access. We've also helped kind of talk to all our partners, whether or not anytime they're referring someone for a complex PCI, if they remember, we try to say, hey, quick shoot if they don't have good arterial access and that, quick give us a shot of the axillary if you're able to, and go from there. A couple of things for most of us coming out of internal medicine, cardiology fellowship, what I always found is we never really learned axillary access or subclavian access in medicine. It was always for, central lines. We were taught, I don't know about you guys, but we were always taught central lines from the neck and IJ, and sometimes you'd have them come up from the ER with like a subclavian, axillary vein line, and we're always like, wow, that's crazy. Why did they do that? Because we'd always do IJ ultrasound access, things like that. So I really wasn't familiar with the anatomy, and it took time for us to kind of understand the anatomy of, the subclavian artery comes up and it goes across. As soon as it crosses the clavicle, it becomes the axillary artery. And there's a couple different techniques. Some people teach a real lateral entrance into the axillary artery. Myself and a couple others, including Jamie McCabe, we do more of an anterior chest approach. The nice thing about that is when you're in the more anterior portion of the axillary artery, you're away from the brachial plexus. Surgeons, when they do a cut down, oftentimes they do a cut down more in the actual axilla. And when you do that, you really are kind of involving yourself around the brachial plexus. If you end up having any kind of injury or compression or hematoma there, you have a little bit higher risk of nerve injury and compression as well. I've done hundreds of cases. I've never had any kind of brachial plexus injury or nerve injury, especially with the anterior approach.
And Tom, real quick, if you go back to that, can you show us how you demarcate exactly where you're going in that anterior chest approach versus, you can see lateral with that pec muscle, sort of where that brachial plexus starts? Just so
I'll show you. I'll show you that as we come up on the other slides. But even if you feel on yourself and you feel up on your clavicle, you'll feel your clavicle come across. Use ultrasound guidance. We're generally entering the artery about 1 finger width below the clavicle. Mm-hmm. And as you come across, almost always your ultrasound will end up right in the deltopectoral groove. And that's almost always where you're going to be entering. There are some superior branches that come across that I'll show you on ultrasound, and then some venous branches, which are really variable. And that's why ultrasound is critically important. But almost every time you're taking the ultrasound and you're coming right up into the deltopectoral groove is where you're going to enter with the artery.
Chris can't feel his deltopectoral groove because his chest is so jacked from all the bench presses he does. That's why he's not feeling it. He's just so swole.
I was going to say either that or is it possible that it atrophied? But, maybe you should skip leg day there a couple times, Yeah.
I'm skinny fat, so I can feel it really well.
The interesting thing about the axillary artery, and it's important to understand this, is anatomically it's much different than the femoral artery. So I love this slide because here you see a subclavian artery. Notice the difference between that and the femoral artery. Look at all the purple fibers, which is the elastic lamina. Look at all the elastic media fibers that are in the entire media compared to that of a femoral artery. And you'll see this. The femoral artery on ultrasound, and when you access it, is very kind of firm. It's muscular. But the subclavian artery is filled with all these elastic membranes in the media. So it's highly compressible. And you'll see it on ultrasound that it's very easy to compress with ultrasound. It's compressible with your hand. But because of that, it's a lot more like accessing a vein. So when you're accessing it for interventional procedures, you got to treat it more like a vein. You got to be very careful. Anterior wall, it's very easy to compress it as you're entering it with a needle and then going through the back wall of it. So it is very different anatomically.
It definitely feels different when you do the perclose on an axillary artery. It feels much more like you're pre-closing a vein. You know?
Yeah, absolutely.
That's why that might be.
This was a really, why go axillary? This was a really nice paper that Jamie looked at, where they looked at all patients who had bad, basically femoral anatomy or vasculopaths. And what they did is they looked at all the CT scans and showed that even in patients who had bad femoral arteries, a large percentage of these patients had actually non-calcified axillary arteries that were relatively free of significant disease. And then they showed the average size of these arteries is usually around 6 to 6.5. And that holds true with what we typically see. So in patient selection, we're typically looking at people who have, suboptimal iliac or aortic anatomy. We all know the reasons for that. Lima or Rima graft is kind of a relative contraindication. This comes more into play if you're doing TAVR from an axillary access. I learned this early on. We had a patient, we put in a large TAVR sheath. Suddenly they got hypotensive, and we really didn't realize that our sheath was occluding their Lima, which the patient was very dependent on. So I get worried about, left axillary if they are dependent on their Lima for their native coronary flow, or if the vessel isn't 2 millimeters greater than the diameter of the sheath. Usually with Impella, given the size difference of the sheath compared to TAVR, I'm usually not worried about this, especially with using a short sheath. And then once the Impella is in, you just have the drive shaft that you're worried about. I generally prefer the left subclavian axillary artery. Some people will teach it from the right. The reason I don't like from the right is, think of all the equipment we use. None of it's designed to come over onto the lesser curvature of the arch. All the equipment we use is designed to come up on the greater curvature of the arch, like you are from the femoral. And anytime you come in from the right, and all of us who do, radial, you understand that your sheaths and your catheters come across to the inner curvature. And when you're dealing with either mechanical circulatory support or TAVR, you end up hitting that inner curvature, and then you stand up a little bit more vertical across the aortic valve. And for instance, with Impella, you can really prop it open and cause a lot of AI. And same thing with TAVR, it can be very difficult to kind of flip your whole system over so you get coaxial with the valve. So I find it much easier from the left side. When we teach everyone, and everyone at my institution that I've taught that does it, we all do it from the left. We'll do it from the right if it's not available, but it's less preferable for us. What do you guys do? Have you prefer?
We do it from the left.
Yeah.
My big thing is from the right. You're crossing so many head and neck vessels. If I can just avoid those, I just would favor it. I'd like to not have the stroke.
Yeah. Generally left for me too.
Yeah, and the other thing is, we do know there's an increase, at least in the TAVR literature. I haven't seen the signal with mechanical circulatory support, but myself and Jamie and Yoshi Taneko published a couple papers looking at our total stroke rate with axillary access, and there is a higher signal for stroke rate, especially in TAVR. And doing it from the left side does allow you to use cerebral protection from the right, which is what we do on every single TAVR case. We go from left side, and then we use cerebral protection from the right. We don't use cerebral protection when doing mechanical circulatory support or Impella PCI, and we've never had a stroke in doing any of those cases.
Wow. Well, plus you want to preserve the right radial probably for the PCI.
Yes, and it does preserve that as well.
One question for you. You mentioned that, and you showed the architecture of the vessel. What do you think about using a balloon to support the vessel when you make the puncture?
I think it's a terrible idea. I know some people do that or have taught that. I think puncturing a balloon with a wire or vessel is just, I think you're just asking for a lot of trouble. It's just not needed. And we can talk about that, especially with ultrasound. I think a lot of the times that technique was taught with not using ultrasound technique and using a balloon and aiming for the balloon. And I'll show you why I think that's a bad idea, just frankly. Some of the things to consider when you're screening these patients is have the people in CT adjust their screening protocol. You know, a lot of times they cut it off at the top of the arch or the lung apices. We changed them to make sure any of the CTs we're getting, we go all the way to the neck so that we make sure we capture these on that. And, you know, typically looking for things like calcium and tortuosity. The other thing to remember when you're looking at this is everyone will start screening and they'll say, wow, there's a lot of tortuosity here in the artery. But you got to remember, every one of these patients, when they put them in the CT scanner, they have their arms above their head. Mm-hmm. So it always creates a turn here, and it always creates a little kink in the vessel that looks like stenosis. It's not true. It's just pseudostenosis, and the vessel's above the head, and it's just non-existent. It's just because their arms are above their head. This is kind of what we're looking for. If you're looking on an angio, just an AP, this is where we're trying to access that needle, basically about a finger width below the clavicle. Why is that? Because that allows us to compress it. You can compress this artery as a single operator with a single finger with not much pressure, and you could kind of maintain your own access there. Some of the things, I put this together just for people to look at. Some of the things you might want to consider, you definitely have to have portable ultrasound. If you want to do a dry closure technique, you could use a 1 centimeter balloon, tip wedge catheter, or peripheral balloon if you want. We typically don't do that. We find that it's very easy to compress the vessel. It just makes the procedure smoother, not worrying about having to do a dry closure technique. You need 2 percloses. You need your bailout supplies. The Gore VBX stents are really nice because the 6 French or the 6 millimeter can go through a 7 French slender sheath through the radial, and it expands up to 8 millimeters. The 8x39 can also go through a 7 French slender radial sheath and can expand up to 11. So having those 2 really kind of gives you a bailout. And I think it's really important when you're doing this that you understand your bailout. Stenting, doing a covered stent in the axillary is we have never seen any kind of complications with that. You're more complications if you don't have a complete good 100% hemostasis at the end of the case. So making sure you have these. I always put an extra scrub tech or partner double scrub if you can, which can help with compression. This little tip trick here, put a blanket or chuck on the floor below you because you're kind of working at the downslope of the drapes, and you always will have a little bit of blood going on the floor, and it always just will make your cath lab staff happy if they're not cleaning it up after. And then this other little one, I learned this by a funny story. Always make sure the blood pressure cuff and the O2 sat probe is on the opposite arm. Early on in our experience, we were doing this like down in the OR. We had the O2 sat probe on the left hand, and we're doing a TAVR. We're getting access, and all of a sudden the patient's sats are like in 50%, and everyone's freaking out. My surgeon is calling for, to prep the chest, and we must have given him a pneumo, and he wants to go ahead and do a thoracotomy and like get ready to put in a chest tube. And then someone's like, wait, where's the O2 probe? Oh, it's on the left hand. Oh, okay, let's move it over here. And seriously, like my surgeon was ready to put in like an emergent chest tube. So, and it's just we were occlusive with the sheath, so there was no there wasn't a good O2 set on that hand. So,
hey Tom, do you worry about the VBX in like kind of an area that's rotating? I mean, is a Viabond preferable, or do you find the VBX works just fine in this location?
The Viabonds are great. I mean, you can get the Viabonds in a smaller French size if you're on the initially they never had the 018 or the 014 system. It was all 035. So the Viabond as a bailout, you needed like 11 French, but now you do have the Viabonds on the 018 or 014 that you can get in 7 French. So I think if you want to use those too, that's fine. I think the VBX really isn't multi-linked. If you look at it, it bends quite nicely. And in the area that you're accessing when you're right below there, generally doesn't have a lot of movement, and there's not a lot of side branches. Even when they raise their arm, that area I was showing is more distal, further out in the axillary. Just a couple tips and tricks on how we prep them. We always prep with our patients like they normally are for cath, with their arms on the side. I know some people like to abduct the arm. I don't like doing that, because anytime you do that, as soon as you start abducting the arm, first of all, you change the whole setup in the room, because now you got to have, an arm board brought out. And we like to learn this technique so that if there's an emergent setting where I need to put an axillary, the patient's already prepped normally for cath. We just run up there, quick uncover, throw a brachial drape on, get access, and go. We don't have to bring in arm boards or anything like that. So it's helpful that way. But also, once you start lifting up your arm, especially if you're like Chris, you bring all that muscle tissue up over there. You start lifting up the chest muscles. You create a much deeper access site, which is more difficult. Again, we usually start with 1 to 2 kind of finger width below the clavicle, so we have a compression. And then you can do a pre-angio if you want to, especially if you're learning. I think that's helpful. But I think absolutely gold standard is ultrasound guided vessel entry. You just have to, and I'll show you why with that too. Sometimes a wire in the vessel may be helpful, so that you, especially if it's your first time, to really understand, okay, I'm sure this is the artery, not the vein, because again, they compress very similarly. And sometimes people put a buddy wire or a safety wire from the radial, and that's okay, especially if you're new.
Hey, Thom, for new operators, I've seen a technique described where you basically take a pigtail up from the ipsilateral radial artery, and you basically stick the middle of the pigtail, and that way you can take like a little pre-angio. I don't know. I mean, it might be helpful for people without a lot of experience, that kind of safety blanket. I don't know. What do you think of that technique?
I think it's a horrible idea.
No, seriously, Thom, what do you think?
Well, I'll show you. I think we all got to be better than that. Our angiographic techniques and ways of, marking the femoral head and doing up and over, those were all good techniques that we created back in the days when we didn't have ultrasound or access to ultrasound and doing these high-risk cases. I think now that we have better tools and techniques, there's just not a need for that process anymore. And I think that's a real old school way of doing it. And I'm sure I might offend people by saying that, but we have better ways. We've evolved since that technique, and there's better ways of doing it. So here's an example of typically what the artery looks like. You can see here that as we're coming across, this is subclavian artery. Once it crosses the clavicle, it's considered the axillary artery. And in this patient, they actually don't have a lot of little side branches until you get farther out. But what I want you to appreciate is ultrasound here. Okay, so right here, this is the artery. Here's the vein. Here's the artery with a wire in it, so you can see it. And here is a little anterior branch coming off the artery. I'll let it play again. You see that anterior branch coming off right there. You don't want to hit it. But also, what I want you to notice is, I'm going to just move this manually, is right here. Look at the vein. So this is very common to have these venous branches that come off the top of the subclavian vein heading towards the shoulder. And you can have multiple of them. And look at the size of this one. This one's almost 7 millimeters. This is a 1 centimeter marking. And this is a big vein. And if you go blind, so if you do your regular technique, putting a pigtail here or a balloon blind, what happens, and we did this early on in our experience too, before we started using ultrasound, you would go through and we'd put our sheath through that big venous branch. We'd get good closure, but the patient would just continue to be bleeding and bleeding and bleeding. You would do an angio and you'd show that you have hemostasis, everything's fine, but they would bleed and bleed, and then you'd have to send them to surgery, and it was because you went through and lacerated and destroyed, a big venous branch of the subclavian artery. And this is impossible for you to see unless you're doing venograms at the same time of your access. And every single patient I do, this is almost variable. It's always in a different spot. It's never in the same spot. And depending on patients, We've had patients who have like big venous collaterals, big venous plexuses where we actually can't even get access on the left side because there's so many veins that will go on the other side. So that's where the ultrasound really comes in. So you see here, you got a little target. You have your anterior, that anterior branch on the subclavian artery right there. You have your vein, and then if you go further out, you have this big vein. So our target spot is proximal to that big venous branch, but distal to this. So you can see that you actually have to traverse an area and kind of thread the needle to get there. And being meticulous about this when it's axillary access is probably the most important thing you can do. Does that make sense?
Yeah. And maybe you're going to talk about it in a second, so don't let me interrupt you. But I want you to sort of describe how you bluntly dissect the axilla and how you get down there, because you mentioned it in your slide before. So.
Yeah. So one of the things we'll do is once we have an ultrasound, and I don't really have a slide on this, and this isn't the best ultrasound to show, but once we've identified with our ultrasound, our probe is right here. You got to remember that the artery is actually not flat like you are when you're a femoral. The artery is actually sloping away from you. So if you have your ultrasound here and you're deciding where to put your needle, maybe I'll do it this way. If you kind of hold your needle at your normal kind of angle that you would do for radial and femoral, you can see that you're actually kind of hitting that at almost a 90-degree angle. Mm-hmm. So you have to actually kind of position your hand down so that you're coming in. And this is the biggest mistake I see, because people come in, they end up hitting the artery at 90 degrees, they put in their sheath, the sheath immediately kinks, they start getting a hematoma off the bat, and the site starts going away from them, especially with Impella, and you're using, the Impella sheath, and so it can kind of rather easily if you have that sharp turn, and the site starts blowing up on them. So you have to kind of drop that angle and have a little bit shallower angle. And the way I always teach it, I always tell people, if it doesn't feel awkward how you're holding the needle, or the per close for that matter, when you're pre-closing it, you're not at the right angle. It should feel like mechanically muscle memory awkward to you. Because you want to do this, it should feel weird. And so if we have the probe up here, we come down here, we'll usually put the needle in. And then what I like to do is, as we're coming in with the needle, I like to keep my ultrasound right where I want it. And that's when I use my ultrasound and use a technique where you just angle the direction and you angle the ultrasound and to find your tip. And then as you slowly go down, you continue to angle that ultrasound to follow that tip until you get to on top of the artery. And that's how you thread the needle in some of these tighter places. Now, if you don't have a lot of venous branches, stuff like that, it doesn't matter. You can kind of hold your target and get your needle there and move your needle. I tend to like to use the ultrasound to watch my needle as we get closer. And so in this case, this wasn't as good of an example of this, but you can see the needle tip all the way down, just distal to this anterior position as we get there on top of the vessel.
And you're using a micropuncture, Thom?
So I think you can do either. I would say my joke is, I always tell people, if you don't use ultrasound, you need to be using a micropuncture every time. If you're using ultrasound and you know how to see your needle, I don't care what you use. So I use a big needle because I can watch my needle tip every single direction. If you like using micropuncture, you can do that. If you're not using ultrasound, you absolutely should be using micropuncture.
I mean, I think this is honestly the biggest challenge with axillary access for me. Is I consider myself pretty good at ultrasound, but it's much more challenging, to be honest, to see the needle tip going in on axillary, and it takes a while longer. And I find with the big needle, sometimes you can see it a little better on ultrasound. So maybe for me, I'd try the big needle, but I love that description of the angle of entry and then the kind of fanning the ultrasound probe.
Yeah. And I would say axillary access is where we really got good with ultrasound. And we started our ultrasound kind of experience all with axillary, and then we moved to femoral, and now we use it in every single lab, whether you're doing radial, femoral, whatever your access is, you have an ultrasound probe on the table, prepped, ready to go. And everyone in our lab uses it now, even for radial. I mean, it makes radial much faster, much quicker and easier. And, You can see the vessels that are occluded. You can see when they're small, where you need to start. I mean, it's just very helpful. So here's an example kind of where exactly you ended up. So we ended up right about where we wanted to be. Remember, we wanted to be about 1 or 2 finger widths below. So that's where we're at. You can see the shallow angle. Typically, we're talking about the needle dissection. So once the needle's in and the wire is in, then I basically make a little slit with a scalpel, and then typically I take a mosquito and just put in that hole and just bluntly dissect a little bit, primarily because usually you're going through the pectoralis major. Now in elderly patients, it's almost non-existent, but if I had to do this on Chris, I mean, I'd have to, do a major dissection and probably get the Army Navy clamps out and hold everything open. But, you have to go through the muscle tissue a little bit. And then typically just put in my 6 French sheath. And then what we do is once the 6 French sheath is in, that's when I heparinize every time. And we do this in the femoral as well. Just because your sheath may be occlusive down the arm, now's the time to heparinize so that the heparin's in while you're doing your pre-close before you put your big sheath in. And then when we do the pre-closure, very similar to femoral, but a couple different minor tips and tricks. You got to remember, again, the vessel is sloping away from you. So you need to hold that perclose down where it's a little bit more awkward. Otherwise, your foot plate is going to be kind of awkwardly only picking up the front. And what can happen is in this, you can really pick up the back wall quite easily. And so you got to hold it down a little bit better. The other thing is as you put the perclose in, typically what happens is as you go in, it compresses the vessel. And so you don't feel it like you do in the femoral. In the femoral, you kind of feel that initial pop and that secondary pop of the perclose. Mm-hmm. Excuse me. You feel that initial pop and then that secondary pop in the femoral. You usually don't feel that in the axillary. Sometimes it's very kind of mushy, and you just feel it. You compress, you push, and you kind of see that you have to be way in there. But sometimes you don't get the blood flow back from the little blood port, and that's because you have compressed, as you're pushing, you've compressed that vein shut, and you're holding it down on top of your perclose, and you don't get blood out the side port. And so sometimes you have to push in, and then you actually have to lift back a little bit. And you'll lift back, and then suddenly you'll get blood out your side port, and that's because you've kind of helped pull that vein back up. So this is probably the trickiest part, and then you got to deploy the foot plate, pull back, see if you have it there, and see if you can stop that blood flow. The other thing is I try to do very shallow, kind of 11 and 1 o'clock, or just both same direction. If you kind of go out really sideways, it's really hard. I think you can damage the axillary artery. And because the axillary artery is a lot like a vein, it's very easy to dissect it and kind of tear it. Versus the femoral artery. So I think when you do your perclose, your pre-close, you got to be very cautious with that. Then after I do the pre-close, if I'm going to do a TAVR, I'll just go in with my stiff wire. But in most cases, if I'm going to do a TAVR, I would go in with an 8 French sheath after the pre-close. And then go ahead and cross the valve, put the stiff wire, our pigtail wire across the valve, and then go ahead and put in our TAVR sheath. If I'm going to do Impella, once I have the second perclose in there, I typically just put the Impella sheath wire through that perclose and put it down on top of the aortic valve, and then go ahead and pull the perclose out, and then go ahead and put the Impella sheath in.
And you're using the long or the short Impella sheath? I mean, it looks like you're going to talk about it now. But.
Yeah, we use the short Impella sheath. When I started doing this, I used the long all the time because I was worried about navigating the Impella through the tortuosity. But it usually, the long Impella sheath kinks so easily through that tortuosity that it was usually a lot more work than it was helpful. So typically we just use the short sheath. If you have a lot of tortuosity, you could consider using a 16 French gore dry seal. Or if you're having bleeding, like let's say, I've had some cases where I proctored where they hit the vessel at 90 degrees. As soon as they put the 14 French in, it kinked and it's causing bleeding. And, at that point, pull that out, hold pressure, and put a gore dry seal sheath in that will allow that turn and not have that kinking.
I think that's an important point, Tom, because I think a lot of people don't realize if you get into trouble with any large bore access, the first bailout, if they're actively bleeding, is always put a sheath back in, right?
Yes.
I mean, because then you
100%.
control the bleeding, you can mitigate it with some sort of either endovascular or even just surgical approach. But I think that's just important to always have that as a bailout, is just stick a 16 French dry seal in, the bleeding will stop, then you can sort things out. So.
Yep, absolutely. And I think that's such an important point, because as soon as you let an access get away from you, you're in trouble. As soon as you get a big hematoma, I mean, you're really in trouble. Your ability to fix that percutaneously starts dramatically decreasing with time as that access site is blown up on you. So really controlling it from the start is what you got to do. One thing we found, putting the side port of the Abiomed sheath towards the floor helps decrease kinking. If you're doing TAVR, having the Edwards label facing towards the patient feet helps the kinking of the expandable portion of it. So those are just a couple tricks. So here's kind of what site looks like. Here's a short sheath. Again, you want to be mindful of where your sheath ends. You don't have, even on the short sheath, in this patient, we left some of it out because otherwise the tip was kind of ending right in the vertebral. And so we didn't like that. So we brought it back a little bit. Being mindful of where the tip of that sheath ends kind of determines how deep you want to put it.
And Tom, the reason that all those sheaths kink more in those directions is that both the sheaths you're talking about, one peels away, which means it splits in half, and the other has a sort of overlapping portion. So you're trying to point that overlapping portion or the peel away part sort of not up and down the way it normally goes, but sideways. That way it doesn't kink.
Exactly.
Right? Okay.
Exactly. And if anyone's doing this, and you have an Impella or you have a sheath that you just pulled out, just play with it and look at it, and you'll see how it will kink easier in certain directions. And so we're just trying to make sure that is not in the direction that we're in. Other than there, once you got your sheath in, putting in the Impella is just normal. I mean, you're on the greater curvature, you cross your valve, you put your Impella wire in, you put your Impella in, and you're ready to go. I think the next question on supporting your case is, what do you think about doing single access from the Impella site? Do you, use the reposition sheath in there? If I'm going to leave the Impella in, I will take the peel away out and put the repositioning sheath in, and then I'll tighten down the pre-closes around that sheath, and also probably do a Z-stitch. And I've done that and sent patients to the floor like that, and also allowed them to ambulate. For a PCI, I just leave the regular sheath in the whole case. You can do single access through the axillary sheath. I can tell you though, it is a pain in the ass. You can do it if it's absolutely necessary, but if you have right radial access or left radial next to it, you will make your life a little bit easier. On the axillary, and we've done plenty of cases single access, but you tend to get a lot of guide interaction, and every time you're manipulating the guide, you can pull on it. It's just a lot to put through from the axillary with that extra tortuosity.
Yeah. Where do you stand?
What's that?
Where do you stand when you do?
Well, you usually can drape it. You can usually drape it from there across and down the body. But it's just hard because you also have, if you're going to manipulate your guide, you have to reach all the way up there. It's just, if you have other radial access, I just wouldn't recommend it. If it's your only access, yes, you can do it. And we've done that. I wouldn't recommend it as a new user of axillary access though. And then device removal, typically remove the Impella, remove the Impella device. We usually put an 035 wire through the sheath, try to get it down into the descending order aorta so you have more more room, I guess, more purchase. And then it's helpful, especially if you're new, to consider putting a catheter either from the radial or from the femoral or from, the left side there, so you're ready to take a picture. You could consider putting an 035 wire across it if you want, kind of as a safety wire. We never usually do that anymore. Usually you can get across if you have an occlusion, which we honestly just did last week, where we must have picked up the posterior wall, tore the vessel, we occluded it. We were able to get across easily from left radial. We came across left radial and we actually fixed it and stented it from left radial.
And I think that's a good tip for everybody, because the radial is the retrograde in this case, which we don't generally think about, but it's always easier to get through things backward, right, especially when you've got a dissection plane or whatever you're working with. Yeah. So that's a nice thing for everybody to know, and a good thing to remind ourselves of when we're working.
Absolutely. And when we remove, generally we'll remove over a J wire. I don't like removing over a stiff wire, just because if you do have that 90-degree turn and you put a stiff wire and you pull the sheath out, that stiff wire can actually cut the vessel and make it worse. So typically we try to do this over a soft J, just to try to avoid slicing that artery open. You could use stop flow technique. Honestly, we just use manual compression. Usually a single operator or a secondary operator can do that. It's important to remove the sheath entirely. Don't reinsert the sheath, and then be ready with your closure tools to close down. One of the things I always recommend from Axillary Access, when you close down, so after you remove the sheath and you put down your Perc closes, if you have incomplete hemostasis, meaning that there's still an ooze, in the femoral, oftentimes we just go ahead and put in another Perc close. In the axillary, before you put in any other additional closure device, take a picture. And the reason for that is you can have dissections, you can have tightening, you can have it closed off. So we always take a picture to see if there's any problem first. And we do that from the groin or the wrist, whatever your secondary access is. If there's no stenosis and it's just additional ooze, adding an angioseal for that final closure, like a 6 French or an 8 French, depending on the size of the leak, usually gives you the best, driest, hemostasis from the axillary site. If there is a narrowing or a dissection, then you're going to be thinking about a prolonged balloon inflation. The last thing you want to do is put in an angioseal or another Perc close. You're going to think about putting in a prolonged balloon inflation, or just cover it with a covered stent. Make your life easy. The other thing is, let's say you close your access and you have no bleeding whatsoever and everyone's high-fiving like initially. Take a completion shot, because sometimes perfect hemostasis is a sign that you shut down the vessel. Yeah. And I had this with one of my junior partners I was helping, do this. He was all excited because he closed it. And he's like, awesome, nothing. And I went, uh-oh. He's like, no, it's perfect. I'm like, uh-oh. And, and we took a shot and we had just closed the vessel. And again, the nice thing about this is you can fix it. It's not like putting a Viabon or a stent in a common femoral. There's very little downside. There's tons of collaterals. I've never seen restenosis in these. And you can do a balloon and see if you get hemostasis, or you can do a covered stent. And you can also follow, like, even if you have, I've done some cases where we've had, good closure, but we've had like residual stenosis and we're worried about. We just check a blood pressure cuff on the arm, see if there's a difference, follow the patient, send them home, just check blood pressures on both arms, and you can always decide if you need to bring them back later to balloon it later. But with axillary access, you want to make sure that you have really good meticulous hemostasis when you leave the lab. It's not like femoral where you can we'll hold it for a while or whatever. You want to have really good hemostasis.
Yeah. And you and Joe touched on this earlier a little bit, but just so we clarify for all the fellows, the VBX is a balloon expandable covered stent, and Viabon is a self-expanding covered stent, which requires a bigger space. There's lots of other brands, Lifestream, et cetera, et cetera. You're just referring to the ones that you guys use.
Correct.
Do you have any preference towards those, or is it just that's what you guys have?
That's what we have.
Got
So it's just for a contract.
And Tom, what about Prote? Do you routinely give Prote for your axillary access? And if so, how much and when do you give it?
We do. So again, the nice thing about this, if you're planning a complex PCI, supportive PCI, you should be preloading these patients in advance. There's absolutely no reason to be loading them on the table. This allows you to give protamine at the end. Kind of depends on the ooze, whether or not we fully reverse them or partially reverse them. If it's a TAVR, we fully reverse them. If it's a complex PCI, left main, we had any issues, we might be a little less aggressive unless we have, kind of any kind of bleeding issues, then we might fully reverse them. But you could give half sometimes too. But again, the worst thing is if you're in this situation and you find out they haven't been preloaded and they're planning on giving, your loading dose here as they're getting off the table, which is the worst situation. But that's where hopefully having a coordinator and people to make sure all these steps are done in advance are really helpful. But this is what it looks like after on a completion site. So you can see our access site there. You can see what it looks like on the chest. Very easy. Post-procedural care. The cool part is bed rest is per protocol for 6 French groin access. If you do all radial, I've had patients sitting up in bed as soon as they get back to the room. The last two, we kind of made up. I don't have any data on how that works, but I tell the patient no lifting their arm greater than 2 weeks. And I tell them no raising the arm above their shoulder for a week. I have no idea clinically if that makes a difference. I kind of stole that from EP. They say 6 weeks. We shorten it up because it's mostly for healing. But
that was amazing.
That was awesome.
Tour de force of axillary access. And kind of my last question, Tom, what do you think the learning curve is, and what is the kind of maintenance of competency, would you say, for axillary? Because, to be honest, I run into it in situations I really don't want to be, where it's like an ACS patient or like a shock patient, and they just have horrible femorals, and then I have to kind of bail out, like you said. But what do you really, what's the real learning curve, and how many should I be doing a year, assuming I'm doing a fair amount of complex PCI?
I think the learning curve is just the access. If you're not doing, I always tell people, if you're not doing a lot of Impella, you shouldn't be doing axillary Impella out of the blue. So first of all, you got to be a site that's comfortable with Impella. So you got to take that out of the equation. Same thing with TAVR. I mean, you gotta be comfortable with the tools that you're normally doing from your normal access. And I think if you're going to do this, I think probably 5 cases is a good learning curve of what it's going to take. It's one of these things. I think some of this helps if you at least see one, maybe do one, have someone help you out. I've certainly proctored a lot of people. I've also video proctored them and stuff too. You can get into a lot of trouble. It takes some experience to kind of figure out how do you get out of that trouble, what are your tools, how to stand. So being comfortable with that. I think the real key to all this is getting your experience on not high risk cases where you need it, not patients who are in shock, and that's where I think doing alternative access for complex high risk PCI in a patient who's a vasculopath, it's elective. It's not quite as large bore as a TAVR. You get experience. Once you get that experience, now you can adapt that to maybe your alternative access technique for TAVR. And having a few cases a year are going to make you proficient enough that when you need it and you need it in an emergency, you can do it. You can do it proficiently and you can do it safely.
Yeah,
that's great, Tom. Awesome. Chris, any more questions?
No, man, that was a great talk. I think that was really not just a review, but just a literal didactic on how we can do this. And I think that what Tom said is important, that you got to be able to phone a friend, and my next Perc Axis case, I know exactly who I'm going to call and who's going to look through my films with me and help me out when I need it. So
yeah, and Abiomed does provide proctors for these cases if you ever want one. So I think it's important to know.
And one thing that's helpful too is once you kind of get over this technique, it's very straightforward. This is all the skills that every interventionalist has. It's just a vessel. It's just how to do it. And it's just, there's always this fear of doing something that we never really did in residency. And it was just kind of always this taboo. But it's a great alternative access, even for diagnostic angios and swans. You know, we always say, like, for our patients who are vasculopaths, it's radial. We always say never brachial. You know, if they have both radial arteries occluded and they're a vasculopath, they don't have femoral access. Personally, we always feel brachial access is almost malpractice. We'll go up to axillary for even just a diagnostic or intervention. If they don't have radial artery access or femoral access, we'll go axillary. We never do brachial. And because you can close it, you can manage it, you can compress it. You know, you have a lot of similar options that you do in those other access where you don't when you're brachial. So
absolutely,
it's important.
Awesome. Well, Thom, thanks so much, man. That was a great talk. We look forward to having you back in the future, and you guys can follow Thom on MurmurMD.
Thanks, guys.
Bye, guys.
Appreciate it.